My dear students, happy to see you again. We have discussed pulmonary vascular disorders in the last class. Today we can discuss a new topic, that is diseases of pleura. Two important conditions are discussed here, that is pneumothorax and pleural effusion. So to begin with, we can discuss pneumothorax, something about pneumothorax. You might have heard of pneumothorax. We have discussed some of its physical examination findings in the initial classes. We can come into the detail later. So then first of all, what is pneumothorax? You all know the lungs are covered by two layers of pleura, that is visceral pleura and parietal pleura. One that is close to the lungs is the visceral, and one that lines or close to the rib cage is the parietal pleura. So there is a space small space in between the visceral and parietal pleura, and there is a fluid also in between the layers. That's called pleural fluid. And the normal volume of this pleural fluid is about 25 to 30 ml. The volume can vary and the volume can be very high in disease conditions like like pleural effusion. Normally it is around 25 to 30 ml. Then about pneumothorax. And coming into the pneumothorax, pneumothorax means presence of air in the pleural cavity, or there will be extra amount of air in the pleural cavity. And normally the pressure inside the pleura is considered to be negative when we compare with atmospheric pressure. When we compare with atmospheric pressure, the pressure inside the pleura is considered to be negative. So it will help in the expansion of the lung during the normal process of respiration. So if the pressure inside the pleura is increased or if it is high, then the lungs needs more effort for expansion. So normally it is kept below the atmospheric pressure. So the normal pressure inside the pleura is negative when compared to atmospheric pressure. Then how the air enters into the pleural cavity, or extra air, how escapes into the pleural cavity? It can enter the pleural cavity through the chest wall itself, then it can enter through mediastinum, then it can enter from diaphragm downward, that is through diaphragm, or from a puncture of the visceral pleura itself, from the visceral pleura, puncture of visceral pleura covering the lung. Then these are the common source of, or the route of entry of air into the pleural cavity. Then regarding the classification or the classification of pneumothorax, depending upon the etiology, we can classify pneumothorax into two varieties, that is spontaneous pneumothorax and traumatic pneumothorax. That's very important, spontaneous and traumatic. The term spontaneous pneumothorax refers to cases which are not due to trauma. All the pneumothorax happening other than due to traumatic cause can be classified under spontaneous pneumothorax. So basically we can divide pneumothorax into two, spontaneous pneumothorax and traumatic pneumothorax. Then we can go into the details of spontaneous pneumothorax. Again, spontaneous pneumothorax can be subdivided into primary and secondary. Primary means it is due to the rupture of apical subpleural bulb, or it is otherwise called benign subcutaneous pneumothorax. It is most common in young men, mainly young people. It's more common in young men. That is primary cause. That is, it is due to the rupture of apical subpleural blood. Then coming to the secondary, many causes are there in the secondary. That is rupture of subpleural tubercular focus, then rupture of emphysematous bullae. You know, when we discussed emphysema, there can be subpleural bullae can be there. There can be rupture of this subpleural bullae leading to pneumothorax. Then honeycomb lung. Honeycomb lung is seen in advanced fibrosis and sarcoidosis, etc. Then in esophageal rupture, then infections other than TB like bacterial pneumonia, then lung abscess, pneumocystis pneumonia, whooping cough, bronchiectasis, and all these this pneumothorax is a complication. Then diffuse fibrosing diseases, pulmonary diseases like sarcoidosis, pneumoconiosis, interstitial fibrosis, then obstructive lung diseases like asthma, bronchial asthma, chronic bronchitis, emphysema. All this can lead to pneumothorax, or this pneumothorax is a complication of all these diseases. Then other than these conditions like cystic fibrosis, then neoplasms, whether it is bronchial or pleural neoplasm, then secondary to spontaneous mediastinal emphysema, then pulmonary infarction, then miscellaneous causes like rheumatoid lung disease, histiocytosis, tuberous sclerosis, then endometriosis affecting pleura. All this can lead to secondary pneumothorax. So the spontaneous pneumothorax can be divided into primary and secondary. So that's about spontaneous pneumothorax. Then the second group is traumatic. Then traumatic is also subdivided into two types, that is iatrogenic, or the second variety is accidental. So two subdivisions in traumatic pneumothorax, that is iatrogenic and accidental. Iatrogenic means pneumothorax happening as a result of some hospital procedures. Accidental means it may be man-made or due to some homicidal activity or due to some accidents. In iatrogenic, the common causes are chest aspiration of chest, then transbronchial biopsy, then needle aspiration of lung tissue, then subclavian cannulation of subclavian artery, then positive pressure ventilation. That is extra, when we give extra pressure to the airways. It is done in positive pressure and expiratory pressure respiration, positive pressure respiration. The extra pressure is inserted to prevent collapse of the lung tissue. So in positive pressure ventilation, then transthoracic liver biopsy. In liver biopsy also there is chance of pleural rupture. Then surgical procedures at the base of the neck. When we in certain neck procedures, there is can be accidental rupture of pleura, because the lung is very much close to the surface in aphesis. So surgery at the base of the neck can lead to pneumothorax in some cases. Then chest compression injury. In the most important one is external cardiac massage, or when we give CPR. In some cases there can be a fracture of ribs during cardiac massage or during CPR. And this ruptured rib can puncture the pleura and can lead to pneumothorax. So these are the iatrogenic causes. Then the accidental causes or non-iatrogenic causes are penetrating chest wounds, homicidal injuries, knife wounds, knife or dagger wounds, then crush injury, accidents, motor vehicle accidents, etc. All this can lead to puncture of pleura, leading to pneumothorax. So when we go into the etiological factors of pneumothorax, we can divide pneumothorax into two, that is spontaneous pneumothorax and traumatic. All the causes other than traumatic are classified under spontaneous pneumothorax, and this spontaneous pneumothorax is again subdivided into primary and secondary. Then coming to the traumatic variety, the traumatic variety is again subdivided into iatrogenic and accidental. So that's about the etiology of pneumothorax. Then we can pass on to the pathology. Pathology is also very important because the clinical features and management can vary depending upon the pathological types of pneumothorax. You might have studied the classification of pneumothorax according to the pathology in second year classes. The changes in physiology depend on the size of pneumothorax, or the clinical features mainly depend upon the quantity of air collected, or depends on the size of the pneumothorax. The air in the pneumothorax is under atmospheric pressure, subatmospheric pressure, or even more than atmospheric pressure. In such cases, if the amount of air is not large, the changes in function is minimal. The quantity of air is very little, then the clinical features will be very mild, or when coming to the treatment side, it may be regarded as a mild variety. The air may be absorbed normally without any surgical intervention. Then if the pleural rupture is very small, also it is closed quickly usually, and air is spontaneously reabsorbed, and it happens in almost all small pneumothorax. The air is spontaneously reabsorbed after its formation. Then there are three types of spontaneous pneumothorax, coming into the classification of pneumothorax according to its pathology. There are three types of spontaneous pneumothorax. That is closed pneumothorax, open pneumothorax, and tension pneumothorax. Again, this is very important. Please note this. We can divide spontaneous pneumothorax according to its pathology into, first of all, closed pneumothorax, secondly, open pneumothorax, and third one is tension pneumothorax. Then what is closed pneumothorax? The opening in the lung is very small and it rapidly heals. In case of closed pneumothorax, the opening in the lung is very small and it rapidly heals, allowing the lung to re-expand. The mean pleural pressure is still negative in case of closed pneumothorax. So it's considered to be a mild form of pneumothorax and has good prognosis. The opening is formed and some amount of air is collected in the pleural cavity, and after that the opening is automatically closed, and after some time the air gradually gets reabsorbed, and the pressure inside the pleura remains negative again. And this type of pneumothorax is classified or named as closed pneumothorax because the opening is closed, or closed pneumothorax. Then the second variety is open pneumothorax. What is open pneumothorax? Here the opening remains patent. So there is to and fro motion or to and fro entry of the air. That is, from air escapes in the pleural cavity, and after that, during the phase of expiration, air escapes out through the fistulous opening or cavity or the air passage. It happens usually in case of a bronchopleural fistula, that is communication between lung and pleural cavity. It happens in bronchopleural fistula. So the opening remains patent, and the lung cannot re-expand in such cases. So the lung cannot re-expand, and the large bronchial communication facilitates the transmission of infection from the air passages into the pleural space. There is more chance of infection in case of open pneumothorax. And empyema is a common complication. Empyema means pus formation in the pleural cavity. The term open pneumothorax is also applied to a pneumothorax resulting from penetrating wound of chest wall. If there is an opening in the chest wall, the same thing can happen. Or that is the opening is remain patent in the chest wall. There can freely move in and out of the pleural cavity. So the open pneumothorax can happen in case of bronchopleural fistula and also in case of traumatic injury to the chest wall. So here the opening remains patent. So the pressure is almost equal to that of atmospheric pressure. So that's the second variety, open pneumothorax. Then coming to the third variety, that is tension pneumothorax. Here the opening is valvular. That is very important. The opening is valvular. Air can enter into the pleural space during the phase of inspiration. That is, during the phase of inspiration, air enter into the pleural cavity, but the air cannot escape during expiration, so that a positive pressure occurs in the pleural cavity. Air goes on, the air pressure goes on increasing. So there is a valvular opening during the phase of inspiration. Air escapes or enters the pleural space, and air cannot move out during the phase of expiration. So there will be increase in pressure inside the pleural cavity, and very large amount of air may be trapped in the pleural space, and intrapleural pressure may rise well above the atmospheric pressure. So air pressure gradually increase, giving increased pressure over the lung tissue. So the lung tissue gradually gets collapsed. So that's one of the dangerous type of pneumothorax, that is closed pneumothorax, and may need immediate or surgical intervention. So according to the pathological types, we can divide pneumothorax into three: closed pneumothorax, open pneumothorax, and tension pneumothorax. And next we can pass on to the clinical features.